Good evening, all the aspirants present here. So, we have moved towards the last session where we'll be completing two domains. And the speaker for this session is Dr. Sangshaptak Saha, sir. So, you may continue, you may start presenting your presentation. Thank you.
Yeah, good evening. So today's topic is basically regarding the EDIC part 1 crash course. So today we shall be discussing a few MCQs and along with that a bit of very brief theoretical revision will be done. So one domain today, these are the two domains today. The first domain is regarding coronary critical care. So that domain actually was taken up by me. So those who have attended the full sessions, they know what to expect from there. We shall discuss mostly some MCQs and the very basics. I shall be going through both the PPTs, just a few, no explanation or anything, but just for revision, we shall go through it. And the second domain was regarding environmental hazards and toxicology. Environmental hazards, I did not find that many MCQs to have come, or but yeah, toxicology is definitely a very important part. So that we shall discuss. Toxicology also, it will be a few MCQs followed by your yeah a few bit of a theoretical discussion also. So in between, I shall be asking some of the candidates or maybe one or two questions because I know despite urging for interactive sessions, people are not that interested to be interactive during the sessions. So I shall not be asking the regular MCQs. I shall be asking the question, telling the answers also. But yeah, in between, I shall be asking a few questions. Somebody is interested, they can speak up, or else I shall give the answer after a couple of minutes. Fine. So the first we shall be discussing a bit of cardiology EDIC 1 MCQs. So 76-year-old woman was seen in the acute medicine follow-up clinic. She had been admitted palpitations at time of admission. Her 12-lead ECG showed normal sinus rhythm. So basically, the patient had a normal sinus rhythm. She had this episode a few times before and they always revert spontaneously. She had no past medical history. An outpatient 24-hour ECG is performed which showed a 10-minute run of AF. So the net result of this question is that the 76-year-old woman had a normal sinus rhythm, but a 24-hour ECG showed a 10-minute run of AF, right? The patient did not feel palpitation at this time. So basically asymptomatic patient, but one episode of palpitations have taken place. So now they're asking what is the first line of management. So you see, this is not an actual cardiac critical care question, right? Because this patient clearly it is a more of a cardiology MCQ, but this is a direct taken up from the past papers of EDIC 1. So you can expect this question because cardiology they expect and respiratory and neuro, basically the stroke management, they expect you to know even a bit of a more outside the very critical care part also, more word based or more OPT based question. So let's see, has somebody answered anything? You can write down in the chat box. Okay. So I shall just wait for a minute. So, uh, so they have given the option is no treatment necessary as a AFE short and self-terminating. So one way of answering this sort of question is what is the first line management is to rule it out. Regular beta adrenergic blocker, I think we know that it will not be the management because that is not a first line management for any of the cases of AF, right? Dioxin definitely not. Dioxin is not a first line management for these things. So one option is pick in the pocket flecainide, which even if we don't know, we shall think that maybe that is the answer. Regular amiodarone, this patient is a 76 years old, but now asymptomatic, so chemical cardioversion is possibly not needed, right? Because the patient did not feel palpitation this time. So rhythm control is, rate control is not needed. So either it's A or it's a B. No treatment because the AF is short and self-terminating. but it is a 10-minute run of AF, right? 10-minute run of AF. So it terminated after 10 minutes. Is there any minute-wise control? It's there. It's in the regular. If you go through the complete AF guidelines, it is a more than anything more than more than 6 minutes is it's a medical management. But even if we don't know, because that is a this duration of AF, that is a cardiologist domain basically. It is OPD based question. So 10-minute run of AF, even if you don't know about this, just by common sense, I think you can tell that 10-minute run of AF is possibly too much, right? So this will not be the answer, and this will be the answer. So if you know the answer, just fill in the pocket figure right. OPD based patient, OPD based treatment of AF. That's the obvious answer. But even if you don't know, that is how you come to the answer. You take it between two options, and then if those options are too similar to each other, you can just choose one. It's a 50-50 chance. It's a better chance if you are blindly choosing four options. So that's what I wanted to show to you guys. So I spent some time on this question. Next question. Again, you read and you tell me the answers or your choices in the option box. I mean, in the chat box. 2 minutes. Okay, because it's a long question, the EDIC actual exam. So it will take some, you need to read the questions fast. As I have told in the previous crash course and also in some of the regular classes also, in such a long stem, it's always better to start with the the options. So here the option is what is the best long-term management strategy? Defibrillator, EP testing, PCI, OPD based, and long-term amiodarone. So now we know it. So now let's see very quickly what's happening. So basically, the 66 years old man who has now come with palpitations and dizziness, hypertensive IHD history, AMI 6 months back, right? For which he had a stent to the LAD. On examination, his heart rate is 190. He's in VT. Blood pressure is 60/30. Respiratory rate, these things are given. No chest pain. Underwent emergency DC cardioversion. Sinus rhythm. His sinus rhythm now showed an evidence of old anterior infarct, which is obvious because they have told that there is an LAD block was there. Prop T was this, and now it has increased. And echocardiogram showed ejection fraction 35%. So basically, this gentleman had a VT which was cardioverted. Patient was like 190 beats and 60/30 BP, and the patient has a previous history of AMI. Troponin T is raised, and ejection fraction is 35%. We have not been given the past ejection fraction, right? So we don't know whether ejection fraction is lower than before or not. So now, what is the best long-term management strategy? So these options are for option A, this second question, right? Option A. So everybody is writing option A, and that is obviously the obvious answer. So it's gentleman with a past history of AMI, now VT. Thankfully, it reverted back, but the next best strategy, long-term strategies, of course, an ICD. So it's a pretty obvious answer. Okay, so it's an ECG-based question. Once again, always if there's an ECG is given, always analyze the ECG first, then read the answer question. So what is the ECG showing? I think it's pretty obvious what the ECG is showing. So it's a 34-year-old woman, palpitations, electrophysiologist for ablation. She had tried the Valsalva maneuver at home, but it had not worked. Vagal maneuver was also no effect. Heart rate 200, blood pressure is okay. So she is okay. So what is this? I think you guys are happening for 81, right? So it's an AF, right? It's an AF with an first ventricular rate. But the patient is not hemodynamically unstable. So let's see what they are expecting. This is the ECG as we have seen. So what is the best treatment now? So it's an AF with a fast ventricular rate and the patient is hemodynamically still stable. So Dr. Srikanth has told option B. We shall wait a few seconds, 30 seconds for the others, and then we shall continue. I don't know why it's coming repeatedly coming back here. So this question is basically between, rate control versus rhythm control. So amiodarone is a chemical cardio defibrillator, as you know. I mean, this is not the answer. This is not the answer. This is not the answer. So those three, I think nobody is thinking of. This is between B or D. So B, IV amiodarone is there, and D, intravenous metoprolol. So as we know, there is no difference between rate control or rhythm control, right? And in this case, the patient has been awaiting for a ablation. It's an AFP first ventricular rate, but still if the patient was hemodynamically unstable, we would have gone for the cardioversion. If the patient had a long history, then again possibly amiodarone first, followed by a cardioversion, as you know, or a TE first to rule out the thrombus, then a cardioversion. Here we don't have to do those things because it's a straightforward, because the chronic history has not been given. If the history has not been given, we can assume that it's not a chronic case. And anyway, it's a 34-year-old lady. So maybe it's an acute onset. So we shall directly chemically cardiovert the patient. It's IV amiodarone is the obvious answer. Intravenous metoprolol can be the answer. When can it be the answer? If it's there was no fast ventricular rate, if the patient's heart rate was not too high, so there we can go for a metoprolol also. But metoprolol is usually not the first line agent. It's usually the intravenous amiodarone, especially in a critical care setting. So is the next question. This Dr. AM, I think this D is for this question, right? Not for the previous one. Good thing. Okay, I think it's for the previous one, right? You went for the intravenous metoprolol. Intravenous metoprolol will not be the answer. Intravenous amiodarone is a drug of choice for AF with a fast ventricular rate, so you can go with that. This one is again, I mean, not actually a cardiologist question, but they love gestational hypertension and this preeclampsia management. They will ask you about magnesium sulfate. They will ask you about labetalol. They will ask you when you deliver the patient. They will ask you what to do to post delivery regarding breastfeeding, regarding everything. So you need to be very thorough with this gestational hypertension and related cardiac events that can happen. So what will be the answer? The answer is you can continue labetalol and reassess blood pressure in 2 weeks. That's a clear-cut answer. Renal androstenedione levels, we already know how the diagnosis is, so you don't need to do that. Methyl dopa is not a first line. This is not required. It's not a pheochromocytoma, and we also don't need to do with that because it's a treat for gestational hypertension, and it can continue, as we know, for 4 to 6 weeks. That's why they have told it will revert possibly by 2 weeks. So we can reassess that after that. So first, before we answer this question, what is the diagnosis here? Dr. Diakane, I don't know for which question you have answered, but yeah, let's wait for the others. If it's for this one, then we shall just discuss. If it's for the previous one, okay. Yeah, this one I think is A. I think nobody has answered actually A, because I think nobody has answered for that question. But yeah, now we shall focus on this. So what is the diagnosis? Somebody just write it in the chat box for diagnosis. After that, we shall discuss the options. Because the question can also be simply what is the diagnosis here? So it's a 38 to so it's a 38 weeks pregnant patient who has presented with features of heart failure, right? Lethargy, breathlessness, gallop rhythm is there, right? So full-term pregnancy, Somali woman, they have given the risk factor also. Yeah, SPPCMP, straightforward diagnosis. Very well done, actually. There is nothing straightforward, right? Every question you answer correctly If you answer it correctly, it's straightforward. If you don't answer it correctly, it's a difficult question. Anyway, so what medication regimen is safe? So it's nothing. It's just we don't have to know which medication is safe in pregnancy. It has got enalapril, so it's not safe. This one got candy certain, again not safe. This one has got okay, we shall keep option C. This one has got RB certain, again not safe. This one has got Ramipril, again not safe. So you see, even without just knowing that ACE inhibitors and ARBs are contraindicated in pregnancy, you can rule out that it's option C that will be the answer. Dioxin is very safe. Furosemide, yes, dioxin, there is some I mean not dioxin, sorry, furosemide, Lasix, there is some controversy, but definitely it's safer than using enalapril. Actually, you see, 38 weeks enalapril is possibly be safe because 38 weeks the fetus, I mean the baby is completely developed, so there will unlikely to be any developmental abnormalities. But yeah, we shall ignore that and we shall just focus on the theoretical part. Any acid emitters ARB is a contraindicated in pregnancy, so we shall just go with the option C here. So yeah, I think Dr. Diakane has already answered option C. Yeah. Dr. Diakane has again answered option C actually. That's very nice. It's option C, of course. So you see, these are the questions that will come in the exam regarding heart failure, regarding CMP, regarding cardiomyopathy types, regarding SES. It will not be something out of the blue regarding infective endocarditis. Okay. So now this is the next question. Just read and as you are doing it, you are being interactive. That's very encouraging actually. I am very pleased because it makes my job very easier because it's difficult, to teach every question answer again because it's a crash course. So then we can discuss all the questions because I have at least I think 20 questions today from each. Poisoning ka 20 and this ka 20. So chest pain, collapse, elderly man, history of IHD, myocardial infarct, history of LAD, drug eluting stent. Investigations, yes, there is ECG, sinus rhythm 60 beats per minute, heart rate, blood pressure 100/70. Okay, so they have basically given out the diagnosis also: loud ejection, systolic murmur, hereditary carotid. So the answer is what would prompt you to refer for aortic valve replacement. So you see, I made the mistake. It's long question, right? So I started by reading the question. If you read this, as I have repeated telling you, but I forgot myself, then you don't have to read the question because it's a directly aortic valve replacement criteria. So let's see who knows the criteria. Okay. We should wait for somebody else because there is a conflict A and E, right? Aortic valve replacement criteria. Basically, you can ask why do you need to know? Basically, as intensities, we don't need to know, but we should be aware that there is some criteria and that this gradient can be measured, right? Because that can be done by our intensities. I mean not we, I do it regularly. If there is an aortic stenosis, obviously, which you don't get that often. So then if you measure the gradient is not very difficult to measure. The size of the valve, yes, is difficult to measure possibly, I agree, but not the gradient. So this gentleman is basically a symptomatic patient, right? So if the gentleman is symptomatic, then basically you don't need any other criteria. It's a severe aortic stenosis and we can directly tell that yes, we will go for a dialysis, I mean, go for a replacement. But if we think that this patient has got significant, is not that, not that symptomatic, then the gradient and these things come. And so the options, so I don't, I Okay, so option A and option E are the only two options being given. I don't know why is that not opening to the page that I'm leaving behind. But yeah. So option A and option E. So valve area less than 1 centimeter square. Valve area less than 1 centimeter square is not a diagnosis, is not a for an aortic replacement. Okay. Is 0.8, I think. So angina and syncope, this patient has been admitted chest pain and collapse. So that alone is a marker of severe aortic stenosis, and you can directly go for it. And besides, you can see the valve area here is given is 0.8 and the gradient is 50. Both are both are indicators of going for the aortic replacement. So it's a symptomatic patient. That itself is a marker. So whoever has gone for option A is correct. Other options are not. Okay, so Dr. AM is telling the it's option A, right? Yeah. So basically, the patient has collapsed in the shower, right? So we know that we need to go for a permanent pacemaker. The other three options are not really actual options. So next is the mode. Do we go for a DDD mode or do we go for a VVIR mode? What is VVIR mode? It's the ventricles which will be set, which will be paced, and which will be like inhibition will be there, and there will be the yeah. So do you need for a dual chamber or no, you need to go for a VVIR? Definitely don't need for we need to we don't need for a VV. We need to go for the second option, right? VVIR. Why VVIR? Because it means that both the ventricles are being paced and inhibitory and R is there. And what is DDD? DDD means we are going for both atria and ventricle. So basically there is an AF, right? So for AF we need to pace the atria, of course. Otherwise it will not work. And there is a collapse, which means that basically the rhythm is not passing from atria to ventricle, atria from ventricle. So we need to pace the atria, pace the ventricle. So the correct answer is option is first option, option B, A. I hope why it is very clear because they can give other scenarios of this also where the option can be VVIR, where it only need to pace the ventricle. Dr. Deakani, you have gone for option E. Stop bisoprolol and start dioxin. That is not the answer, okay? The patient has collapsed in the shower. A collapse is a direct indication for pacemaker, especially when you know that the collapse is possibly because of an atrial fibrillation. So it's a huge question. So we shall directly go that what is the best interpretation? This will not come in the exam. Okay, it's a previously asked question, and I have kept it, but it's a for a long time back. So actually, I wanted to hide the slide, but I forgot. So we shall just move on to the next question. All of these questions are previously asked questions. Okay, and these questions are a bit difficult questions. That's why I've kept it in a crash course. All the questions of Vedic part will not be this difficult. It's a pretty straightforward exam. So if you're working in ICU, if you practice a bit, you practice doing the MCQs, you have read up some brushed up your theories, you will definitely pass the exam. I mean, if you are not passing the exam, either you are not working regularly in the ICU or you are, you have not prepared that well. That's the harsh reality. I'm sorry, I mean, yeah, that's the harsh reality of the thing. It's not a difficult exam. Okay, so yeah, I'm just waiting for you to. Okay, let's see what you guys have answered. Okay, so it's A, B, B. Okay, so let's see what the options are. So basically, what is the question about? The question is basically about in case of AF with fast ventricular response. He's taking an amipril, non-hypertensive. So now the patient has presented with palpitations of 3 days. And finally, what has happened is that the pulse rate has come down to 85, 80, 85, 90, something like that. But there is an AF. His BP was 130/60. And the question was whether you need to take long-term aspirin to prevent a stroke, right? So he's at a high risk for stroke. So option D was pretty straightforward. Yes, he needs long-term aspirin. I mean, that's pretty obvious. We need a long-term aspirin. Not sure. So that will not be the answer. And why aspirin? I mean, aspirin is the antiplatelet, right? And here we are mainly looking for anticoagulant. So this will not be the answer again. So this is how you analyze the options. No, you can stop the aspirin. So this is, this is some bull story they've written. I don't just to fill up the answers. So basically, the actual options are between option A and option B, right? So now here you need to calculate the Chadha score. What is the Chadha score here? Has somebody calculated and told the options, or somebody? If somebody has calculated the Chadha score for this question, please write yes. I mean, there are three people who have answered anyway. So if either of them, of those three, have calculated Chadha score and then given the answer, just write down yes or no. If you have not, you have to calculate a Chadha score. Without calculating a Chadha score, you will not be able to give the answer basically. This is why they have given that the patient is hypertensive. They have given the age of the patient. Okay. So what is the Chadha score here?
It's whatever wasn't there. It wasn't in your thing. But I took out the things in you. I hope I didn't
I don't think anybody has calculated Chadha score and told the answer. So you see, you have to have some logic. I mean, why have they given the animal strokes 3%, 6%? Because once you calculate a Chadha score, then you will against that there is an animal stroke risk. So Chadha score, the chart you have to be known. You have to be thorough with it. And the answer is option A, obviously, the 3% chance that will be the Chadha score. Because here, the patient that has only got hypertensive and the age is there. Otherwise, there is no other risk factor. So the annual stroke risk will be lower. It will be 3%. So option A is the answer. But to which whether you go for option A or B is not that important. Whether you are calculating the chat versus to score here, whether realizing that the examiner is asking you about that, that's very important. Okay. So again, the score based. So just a basic idea you need to have regarding grade score. What do you need to have? Basically, they are wanting to know whether the thing AKI is in AKI or CKT is interested or is is involved in the grade to score or not. Whether you know that or not. That is the point that you want to see. So yeah, serum creatine is one of the risk factors. So that is the answer. Not risk factor, one of the scores. So this is basically again, if you read the second is told by a friend to stop the navigator, she was at high risk of bleeding. So that is basically the Hasbled score. The Hasbled score, as you know, Hasbled score is not really regarding the don't need to stop the bleeding or anything like that. Even if there is bleeding, you can even if there's a high risk of bleeding, you can continue with the dabigatran. But you need to inform the patient that yes, you are at a high risk, so you should be seeing what you are doing and those sort of things. Yeah. So this will be the answer. So you can continue with the thing, but you need to inform her that she is a high risk. So she should be, self. Whether it's dark stool, whether there is some blood in the sputum, some blood with the cuff. So those things the patient needs to look at, and they can continue dabigatran. Next question is this. So what is the question about and what is the answer? What is the best? Why has it presented? There is a diffuse dull aching central chest pain which is no longer there, right? These are subsided. And so now basically he has got a very recent history of this cardiovascular defibrillator implantation with 5 days back, isn't it? So best step is will be this one. You shall do a chest X-ray, you shall do echocardiography, but it's very unlikely that there will be some findings with this. So what is the next step and what is the best step will be different. Next step will possibly be either one of these, but the best step is definitely you are checked because it's a new device, so maybe it's not working properly. So I think look at the ECG tells us what this patient has, and now the patient has also presented with a severe retrosternal chest pain. There is a ST gallop. There is bilateral palpitations in the lower zonal lung field. So least useful in the management of this patient. I think it's a very critical care question, right? 110 by 70 pp, oxygen saturation on air is 94%, JVP is 12 centimeter. Patient two-thirds lung field auscultation means there is pulmonary edema. Supplemental oxygen is possibly not needed here. 94% is there. Invasive pulmonary artery catheter, we use it in these scenarios, but yeah, it's which is least useful. Yes, it's least useful. This is the standard of care in this case, B and C. So B and C will not be the answer. So we are confused between this one, and this one. So now the saturation is 94%. So now he does not need it, but it's not least useful, right? Pulmonary artery catheter is very useful actually, but we are not using it because we have a simpler device. So it is again not least useful. Dobutamine you are using basically in conditions where the patient is having a mixed shock or whether there is a peripheral vascular resistance is too high. Here we are not given any condition, any clinical characteristic which will tell us that the peripheral vascular resistance is high enough. So it's option A which is the correct answer. Dobutamine has got no role at least this stage of management. Yeah. So what is the ECG showing? Yeah. So what are you dealing with here? What is the ECG showing? So what is the ECG showing here? The ECG is showing an AF, right? And I mean, they have given irregular also. 90 by 50 is the blood pressure. And there are, of course, there is some ST depressions in lead 1, lead AVL, and some STTF changes also. So what do we go for here? Antibiotics for CAP, anticoagulation, delay rhythm control for 3 weeks, rate control, rhythm control with heparin cover. So as soon as they're telling a rhythm control with heparin cover, we need to calculate a Chad-2 score. Okay. Here they have given some information regarding a Chad-2 score. The age is of course there, and the age is there, and nothing else is there otherwise, right? The blood pressure, those things are mentioned. So it with the female sex as such, we shall get a where we need to give some heparin cover also. So possibly here we need to give some rhythm control with a heparin cover. Option E is the answer. We don't need to delay the rhythm control for 3 weeks. We can, because this is an acute presentation, right? So basically, it's an infective endocarditis ka question. Blood culture is in Coxiella barnetti, and we have got pretty much evidence, good evidence of IE from the question stem. So basically, they have asked whether into the blood culture, whether when into the transit record these things. Normal, be performed antibiotics. So we need to know infective endocarditis. Infective endocarditis, the feature is that here the patient will be diagnosed the infective endocarditis based on the minor criteria, right? So you don't need to send a blood culture. This is definitely one option which can be the answer. There is no guideline regarding this. There is no guideline regarding this. So definitely this is the best. By minor criteria, we have diagnosed the eye and the treatment should start immediately. So it's a pretty straightforward answer. So yeah, I am seeing the answer. So yeah, option E and those things are right. Yeah, fast A, so rhythm contour heparin cover, right? Yeah, absolutely correct. So what about this? What is the answer here? Last two questions from cardiology anyway. After that, we shall do a few of poisoning. Okay, so doctor has told option E. Set a sensitivity to 3 volt is the answer, right? The threshold has been found out, so we need to set a sensitivity. So these questions are basically not about this question alone. This basically means that you have to study about infective endocarditis. You have to study about pacemakers because many of us are very weak in pacemakers, right? Then you have to, of course, study about the acute coronary events, and you have to study about those, cardiomyopathies, PPCM, of course, AF and the different rhythm changes, bradyarrhythmia, the heart block, those things. If you are good with these 7, 8 things, I think you'll be good for the exam also. This is, as you can see, this is once again a previously asked question, but it's a not an ICU question, right? So it's how you diagnose coronary artery disease. So what is the answer here? So question number 14. I think Dr. AM is saying that option B for this answer. So CT coronary angiography. CT calcium scoring, actually it's a past question. So there the answer was given as CT calcium scoring. But as per the recent guidelines in 2025, CT calcium scoring has been ruled out. So yeah, I don't think this question is asked because of the change in the guidelines. But if it's asked, I think it's better to go for a CT coronary angiography. Yeah. So it's an image-based diagnosis. So what is the diagnosis? And tell me the question is what will be the treatment. So tell me the diagnosis and then the answer will become. Yeah. So it's an aortic dissection and it's in the it's in the both the parts, right? Both the descending and ascending, you can see. So we shall consider for the descending part, and here the blood pressure and these things are on the higher side, so to come down the blood pressure, and there is no surgery for descending. It's you have to come down on the blood pressure, and the patient ascending and descending, yeah. So you have to come down on the blood pressure, and you have to plan for a surgery. You have to come down on blood pressure using beta blockers, and depending upon whether it's an ascending time type A or type B, we can go for the surgery. So basically, low molecular heparin, PCI, clopidogrel, ACE inhibitors don't have any role. So if this as option is given, it's urgent surgery only. But if in this question they have gone for a beta blocker first, always go for a beta blocker to reduce the blood pressure. Here the option is not there. You really can't do anything. Yeah. Here in this case is option E, no doubt. So that's it for cardiology. Now a brief discussion on poisoning, because poisoning ka question there can be one or two questions at the most. I don't think there will be more than one question even if it comes in the exam. So I've kept it just to give you an idea about what poisoning cases can come. I would read the question. So the patient is on ICU on propofol, midazolam for quite some time. He has not responded to 2 liters of fluid loading, and now he has bradycardia and hypotension. And the laboratory values have been provided to you. Just go through it. So what is the diagnosis? Yeah. So propofol infusion syndrome is the diagnosis. Yeah, yeah. Sodium to value na 134. Actually, I have myself written these values down. So one extra 3 has come. Yeah, sorry. So anyway, so what this question was about is the obviously the propofol infusion syndrome. So the creatine kinase is also raised, right? So they can either ask you about the diagnosis, they can ask you about the management, or they can ask you something regarding the rhabdomyolysis part or the cause of the high lactate. So the answers will be similar. So I have not got a single MCQ, with the usual question with the answers, those sort of things. But just a scenario they have given, and there can be lots of questions that are coming from that. So you need to know about propofol infusion syndrome. You need to know rhabdomyolysis, and you need to know about the different causes of high lactate in the ICU, because that can come in a lot of ways. Okay, what will be this? Yeah, OPC, na? Organophosphate poison. Sorry. Okay. So these are the values that I've given. I mean, from the values, that nothing much to to gather. There's a lactate is high and creatine is high. But you see, you are going for the EDIC exam, right? So EDIC is an European exam, and in those parts, organophosphate is not that common. In India, yes, the farmer found collapse under a tree, regardless of what is else there in the question. It's a OPC poisoning. There's no doubt about that. But for this exam that you guys are preparing for, if this sort of question, even if you think it's an OPC, think again, because OPC is not very common there. So they don't give that many OPC cases in the exam. Besides this one, the green stain of his lips with mouth and lip ulceration, not the green as any stain, okay? Stain of the lips and lip ulceration, oral ulcerations, all these things is what it is paraquat. So the diagnosis is paraquat poisoning. So basically for paraquat poisoning, what how you treat is basically there is no effective treatment. So basically you go for, so it's paraquat. Sorry for the autocorrect. Yeah. So it's paraquat poisoning. So regarding paraquat, what's important is that there is no specific treatment. You can use Fuller's earth. You can go for hemadsorption, dialysis, and ECMO has come up a big role in management of these patients. So this is the next question. Poisoning in EDIC 1, only diagnosis and the treatment. That other than that, they will not ask anything else. So basically, decreased GCS, seizure disorder known patient, investigations are as follows. So ammonia is pretty high, which is 156. Okay. So what will be the cause of hyperammonemia? Just write it down in the chat box. So once again, this question can come as a benzodiazepine poisoning. It can come as one of the DDs of low GCS. It can come as a CT scan, whether the patient may be having hemorrhage or a stroke. It can come as a poisoning case. Okay. Has anybody answered anything? So I shall just give out the answer. So treatment for seizure disorder with a high ammonia. This means the patient was on sodium valproate. Okay. So you need to stop that drug, or they can ask you which drug possibly the patient was on. The answer is sodium valproate. It's notoriously known for increasing ammonia. So you have to basically stop that drug and see how the response is. Okay, and again a very straightforward question. Poisoning question will be very simple to answer. If you just brushed up your poisoning things just before the exam, it will be it's a very high scoring thing. Okay. So once again, a very exam favorite, right? High osmolarity. So you need to know about the poisonings that can cause, not the poisons only, the causes of high osmolar gap, high anion gap, and where the high anion gap and high osmolar gap stay together, and where the high anion gap but without the osmolar gap comes. So all of this you need to know. So what is that? I think the answer is pretty obvious. The answer is pretty obvious. It's an ALF, DILI, methanol, hooch. Yeah, hooch. Why is it called hooch? The answer is methanol, obviously. I mean, not the hooch. It's this poisoning is this. It will be some rural areas, and they'll come to the city, and they will very strange names, and it's very difficult to know what they're talking about, right? Yeah, it's a very interesting thing, poisoning. A very overlooked thing in critical care also, and in general, but it's very, very interesting. I think you guys are working in the ICUs, or I think you guys are working in the ICUs. So urine poison test is something that we need to do whenever we get a patient who is unconscious, and we don't know why exactly the patient unconscious, other than just relying on the fact that yeah, तो sepsis में है इसलिए GCS कम है. If it is not explained, always rule of poisoning. You never know. We have got 2-3 patients in the last couple of years who has got some medurazepine came positive in the urine. One patient has got some cocaine in the urine. So yeah, those are the things. It's not related to the exam, obviously, but yeah, from practical point of view regarding poisonings. Otherwise, in most of the cases, the patient relatives will tell you, yeah, Doctor Sab, yeah, the patient has taken this. So you don't need to diagnose anyway. So this question is very interesting. So this question basically tells, okay, so we shall just do it, and then I shall tell you why it's interesting. Sodium is okay, hypokalemia. Chloride is okay, bicarb is okay, low, so there is metabolic acidosis. Urea is high, creatinine is high, so there is AKI. Magnesium is low, phosphate is okay. Phosphate is low, sorry. Corrected calcium is on the higher side. Creatine kinase is okay. Blood glucose is, of course, very high, and lactate is high. So it's an acute metabolic, so it's an acute kidney injury with metabolic acidosis with decay-like features, and there is also hypokalemia, right? So this is and there is a dyslipidemia. And the patient takes ramipril, the patient takes fluoxetine, metoprolol, theophylline, fluticasone, salmeterol. So fluticasone, salmeterol not cause the poisoning. I think that's pretty straightforward. Ramipril can cause the poisoning, definitely can cause the poisoning. Fluoxetine, metoprolol. So what else have they given? They have told that there is a atrial flutter with high ventricular rate. So metoprolol ruled out because that will cause your bradycardia. Normal QRS, normal QTC, ruling out your fluoxetine, that will be causing a raised QTC. Ramipril poisoning, I don't know ramipril poisoning कितना होता है, but ramipril will mostly increase the potassium, so hypokalemia is there, so it's not ramipril. So in this way, even if you don't know the features of the poison, you can just rule it out, and you're left with theophylline, right? So theophylline can cause anything. Theophylline can cause this, it can cause a tachyarrhythmia, it can cause these tonic seizures, and it can cause this respiratory failure requiring mechanical ventilation, and of course the hypotension part, oxygen need, anything it can cause because of the aspiration and those things. So its answer is theophylline. This is not the answer, okay? This is something else. We shall discuss that. It's not TCA toxicity. Okay, in TCA toxicity, there will be raised QTC, and there will be a raised your the QRS will be prolonged. So it's definitely not TCA. That is why they have given the QRS and QTC. Always be careful, because always think, why have they given this QRS? Why have they given this QTC? They don't give QRS QTC for every question, right? That's why they have given it, so that you can rule out the fluoxetine. Anyway. So these I have not kept, but you need to know about just how to diagnose the management. Carbon monoxide poisoning is nothing but high pressure air, hyperbaric chamber. Dioxin, you have got separate brand. The separate this DigiBind, which you should be using. calcium channel blocker, beta blocker, it needs a separate class, so I've not included it here. Because if I've included CCPBB, we have not gone to anything. So I think in your EDIC normal course of this institute, you must have gone to CCPBB poisoning in your toxicology lecture. So yeah, go through it. That's the most important part. What is this? So basically, plastic manufacturing unit, hypoxic, high lactate shock. The diagnosis is cyanide. You have to know this. These are correlations. Plastic, and you will know the answer is cyanide. The antidotes, I think you are aware about methemoglobin and your sodium nitrite. So and hydroxycobalamin. So whichever this answer is given in the options, just go through it. Just go with it. And if the patient is very deficient, don't go for the methemoglobinemia. Okay, it will cause severe hemolysis. Then go for vitamin B. Then go for hydroxycobalamin or sodium nitrate. So apart from the MCQs, because I have not gone with you guys regarding the poisoning ka whole PPTs because that was not assigned to me. Like I have gone to the uh, cardiac critical care in great details, so 3 classes. So I have just basically not to teach you about this, but just to show you what you need to know. You need to have basic idea about the poison that can cause bradypnea, tachypnea. Among that, you need to know about epinephrine, cyanide, methanol, these glycols, regarding osmolar gap and these things, salicylate definitely, ethanol, sedatives, overconophosphorates, opiates. So most of them are pretty useful. Botulinum and venom, those will not come in the exam. Circulatory status, again, as I told, beta blockers, calcium blockers are very important. Opioids, OPs again. Anticholinergics, cyclic antidepressants, basically the tricyclic antidepressants, those are also very important. These are similar, but do know about sympathomimetics and which one causes dilated pupils, which one causes constricted pupils, and those sort of things. This hyperthermia is very commonly asked in the exam. Okay, malignant hyperthermia, urinary malignant serotonin syndrome, these withdrawals, salicylates, carbon monoxide, others in discuss opioid ethanols. So just take screenshots of this so that it becomes easier when you are revising. This is basically an activated charcoal. This is from my PPTs when I teach about poisonings to in other 81 courses in details. So just go through the activated charcoal for indications, contraindications. When you shall not use activated charcoal because that is a more commonly asked question. Multiple dose activated charcoal, the contraindications. Then in which cases we'll use the carbamazepines, phenobarbital, dapsone, quinine. So the mnemonic is CD PQT. This is, I think you will laugh at this, right? What sort of mnemonic is this? But this is the mnemonic which I use when I prepared for the exam. So that kind of stuck with me, and that is the one which I now use it to teach the other next generation of EDIC 1 candidates. Whole bubble irrigation, again, contraindications are very important. Don't miss if these contraindications are present. This is a very common indication because these illicit drug packets is probably not that common in India or in this our part of the world, but in their part it is very common. So basically, where we are using it, you have to remember hemodialysis for these, hemoperfusion for these, and of course the multiple dose activated charcoal for these. Hemoperfusion, you can see theophylline and paraquat, as I have told in the paraquat when I discussed these two answers, right? And hemodialysis for most of the cases, we are not preferring hemodialysis because those do not come out with the dialysis, but exceptions are these where you can use the hemodialysis or a CRRT, right, to remove the poisons. These are some of the syndromic approaches which you need to know for the exam. And yeah, that's it. So this was about today's crash course. Time given was around 1 hour to me. So just in details, I mean very briefly, I have tried to incorporate the parts which you need to know for the exam. I mean, it's not possible to teach about poisoning and acute pulmonary care in 1 hour, right? So yeah, all the best to you guys. And if any questions, you can just mention it in the chat box later or mention it to the Farz Academy. They will get back with me. Yeah, you're most welcome, doctor. Yeah, it's a pleasure to teach about EDIC 1. Okay, so I shall end the session here.
Thank you, everyone. We'll be having the next session tomorrow at 7 p.m. I'll be forwarding you the link. Also, we'll be having a session on Tuesday from 7 p.m. onwards, and there will be one to two domains which need to be covered. So, we'll be doing it within this week. Also, all the students who are appearing for the EDIC examination, you'll be getting the recording of the same EDIC crash course. So, do give me a notification in my WhatsApp. Thank you, everyone.